And that is basically the basics of trauma-informed practice. So here is a definition of trauma-informed practice. So it's a model that is grounded in and directed by a complete understanding of how trauma exposure affects service users' neurological, biological and social development. It is not about eliminating or treating people's trauma, but about creating a safe space in which enables people to get what they need from their engagement with you. So you're not there to help that person feel better. You are there to make it possible for that person to ask for what they need from you. Does that make sense? So I'm not saying that you've got to be really lovely to everybody and talk people down and fix them. I'm saying it's about just using certain things that make it possible for them and you to do your job well. So here are the principles of trauma-informed practice. It's to realise that trauma can affect individuals, groups and communities. To recognise the signs, symptoms and widespread impact of trauma. To understand, actually, it's not on here, but to understand that you don't know who's got trauma and who hasn't. You can't tell by looking at a person if they have a significantly traumatic past. And I think people think they can sometimes, and actually it's about using these principles for everybody that you interact with. To prevent re-traumatisation. You know, as I said, what tends to happen is when somebody has a bad experience and it ends up with trauma on top of trauma. And people don't feel safe, you know, and when people don't feel safe, it can be very re-traumatising. I like this one, but it's difficult, and it's to see beyond an individual's presenting behaviours. And as someone that worked in customer service, has worked, you know, behind a pharmacy, I've worked on phone lines, and I've worked in, a lot of my past is actually in facilitating recovery meetings. Sometimes this is a really, really tricky thing to do, because when you are being shouted at, it's really difficult to see past it. But it's about really making the effort to try and see past those presenting behaviours and understand that a lot of the time the presenting behaviours like anger is because they want something and they can't express it in the way that maybe they'd like to. What do they say? What's that saying about, if the only tool you've got is a nail, if the only tool you've got is a hammer, you treat everything like it's a nail. And I think that's really true sometimes with people. And you can see this a lot in people that have grown up in very angry households or maybe loud households where people don't communicate in a normal, calm way. Communication is mostly done with shouting. And actually, when people go out into the world and they try and have these conversations, a lot of the time they fall back into what they know, so they fall back into being shouting. And actually, when I was in the GP surgery the other day, I saw some signs up that said abuse, about no abuse. And what can happen is that when people are talking very loudly, we can get really scared. And it can seem like abuse, but it actually might be that that person is just trying to get the point across. And it's about trying to keep that in mind, that some people may just communicate in a louder way. And then an important one is to ask what this person needs rather than what is wrong with this person. And that, again, is another thing that can be quite difficult if somebody is presenting as very angry, or maybe they're not saying anything at all. Because some people find it really, really difficult to actually just verbalise what's going on. Maybe they've come from a place where they weren't allowed to speak. You know, they've always had someone with them that's told them exactly what to say and what to do. And it may be that they're not answering the questions that you want. And it's about really seeing that isn't what is wrong with that person. It's really trying to find out what that person actually needs. So I'm going to hand you over to Nicola now, because we're going to look at the principles of trauma-informed practice.
It's all gone. Just click it on. Is it on? Yeah, so for Oh, they're all coming out now. Just wait for them all to appear. So, in a minute, but not quite yet, we're going to do an exercise, because the 6 key principles of trauma-informed practice are, I'll read it out from here, then I can look at you. Safety, trustworthiness, choice, collaboration, empowerment, and cultural consideration. So within all this, we want to keep our environment. We want to create a safe environment, a trustworthy environment, where we create a trusting environment where we create trustworthiness, an environment where we saw on the video around choices. You know, just give it. I know when my children were little, and I'd got a win-win if I offered them 2 things, and they were in control of what that choice was. I had to make myself aware that I've got to deliver on both. But if somebody has choices, they feel in control and feel power over what's happening next, not powerless. And collaboration, it's about, you know, everything is about working together. And empowerment. When we feel empowered, we build our strength, our capabilities. It gives us confidence in ourselves. And we also need to create an environment of cultural consideration, where we're responding to that individual's needs, where we've had, you know, some insight, and they've given us insight into what their needs are to make that safe space. And I think in the video that we saw, there was some very small things that people did towards the end of the video that made a really big difference to create all these things in one environment. And I understand that to do this, it sounds like a big ask, but I'm sure that there's things that you're already doing and building on that can be expanded, and from the information that you've gathered today, that can spark ideas to how we can make our environments that we work in better for you, and better for the patients, and better for the services that are offered in there. So we've got have we got an exercise next? Yep, we've got an exercise. So it's a table exercise, but obviously we haven't got any tables, so we've adapted. So we've got an exercise for you all, and you might have noticed that there's flip chart up on the wall with the headings that are on here. So I don't normally deal with a room as big as this, so we're going to split the room up. So into the 3 rows each. So the first 3 rows on this side, I've got to put my glasses on. Yeah, it says collaboration. So if the people on the 3 rows at the front can think about how can you make your workplace a trauma-involved environment, specifically around the topic collaboration. And we've got some post-it notes, and if you've got a pen, there are some pens on this table here. And if you wouldn't mind just writing your thoughts and ideas around how you can create a more trauma-informed environment on collaboration. And then if the 3 rows behind can think about empowerment, and then if these 2 rows, because for some reason nobody sat on the front row, if these 2 rows can think about safety, and then if the 3 back rows can think about trustworthiness, and the 3 back rows over there think about choice, and the 3 rows at the front think about cultural collaboration. So we're going to give you, how long we're going to give you, Dee? 10 minutes?
No.
Bit longer?
Yeah, give it 20.
We'll give you 20 minutes to think about those topics. Talk to your colleagues or the people, make a new friend, and think about what it is. There's post-it notes and pens, and pop it up on the wall.
I just want to say, before you begin, it doesn't have to be really sort of big ideas. It can be really, really simple things. Yeah. So just the small things that you can do. So it could be as simple as, I'll just give an example. So empowerment. If somebody looks like, if they've come into the surgery and they look incredibly flustered and anxious, it can be things like saying to them, well done for getting here today. you know, just really simple little things. And things like safety, if it looks like they're getting really agitated by things like the loud music that's happening, it can be just turning it down. So it's not the big ideas, it's not changing walls or setups, it's just the little things that you can do that might help people feel safer in the environment.
And remember, all ideas are good ideas, so don't be afraid to have, if you've been thinking about something for a while, get it down. You know, every new thing starts somewhere, okay? And remember all the wonderful things that you do. Thank you for that. I think it's some of it may have started a bit slow, but once you've got those ideas going, we've got loads out there, so that's brilliant. And my colleague Julie's going to pull it together and be able to put it in a document so you can share it between your practices. So even though you might not have worked on the topic, you'll be able to share what's going on, so that's really good. And yeah, thank you for that. I just also wanted to let you know that we're aiming to finish, if it wasn't clear at the beginning, at 4:30. Obviously, if we do finish earlier, then obviously you can go earlier. But the last call, well, the latest will be 4:30. So what we're going to do now is we're going to pass the mic around, and we're just going to read what's on the wall, so you've got an idea of, if you weren't in that group, what's been going on for everybody else. So I'll just pass the mic to my colleague Rose, and she's going to read out collaboration and choice. There you go, Rose.
Thank you. Okay, so I'll start with cultural consideration. We've got quite a number of responses here. Yeah. So we have got signs in different languages, plus prayer, preferred names and pronouns, prayer room, and breaks for this, leaflets, information for all patients to manage expectations. We also have employing people from different backgrounds as well as ages, inclusion of is it? Working from home. Yes, working from home staff, ensuring that staff are trained on the topic. Also, gender of clinician, that is choice there, choosing the gender that one would prefer. Interpretation services, aware of disabilities. Is that so? Okay, and finally, religion. So this is what has been discussed on cultural consideration. Yeah. Okay, and then moving further, choice. So there are also quite a number of points raised here. So give choice of appointment time, and then choice of male or female, choice of outcome of the appointment, that is consultation, offer of GPs or PAs or pharmacists or ANPs, discussion in a private room also, choosing preferred clinician, male or female, choice of hubs, out of hours, if someone wants to be saved out of hours, telephone or face-to-face, offering any alternatives, exposing the situations as well as the outcomes, choice of communication, writing it down, or maybe if someone needs an interpreter as well, and then choice of someone going with you, offer to wait outside the building whilst you wait, secret, printed or, sick note. Can it be printed or should it be electronic? And then sending the patient to a pharmacy of their choice, online services, if they need online services, choice of site, refuse treatment, and this is the last one that I couldn't read, continuation of the same receptionist or clinician. So these are the points raised on choice. Thank you.
Right, we're going to do trustworthiness now. Wow, you'd be sick of my voice at the end of this. Right, for trustworthiness, we have listen, we've got build rapport, provide routine, we've got be friendly, listen and empathise, very important, consistency, consistent approach, yes. Follow through with your actions, really, really important for this one. So if you say you'll do something, follow through with it. Follow through with discussions. Familiarise and personal chat. Have I read that right? Positive body language. Kind, polite greetings. Create a comfortable environment. Empathise, fantastic. Follow up things with an issue and get back. Be open and honest. Non-judgmental, that's important. Clear communication. Making feel safe, creating a safe space. Follow through on actions. And friendly. Oh, kind, polite greeting there. I missed that. Fantastic. Yeah. I'm just going over to safety. So we've got having music on or confidentiality. Being able to talk to a female or male person if needed. Data protection, not sharing information with other people, very important. Empathy, shows, sorry, I'm not sure what that says there. Respect, is it respect? Sorry. Yeah. Shows respect and safety. Listen to a private room, safe space. Appropriate clinician and chaperone. So, well done. I'll just pick up the last two.
So on this side we've got collaboration. So we've got working together, and we've got achieving a common goal together. Brilliant. Listening. Got my wrong glasses on, sorry. For warning clinical team of trauma when attending upset. Oh, right, on the screen message. Yeah, so I'm guessing that means giving forewarning to somebody. So letting somebody know if somebody's in distress so that they can prepare and give that message considerately. Thank you. Patience, yes, patience. Patience for the patients and patience for the staff, yes. Working with the patient to support their needs, that's so important, yeah. Reassurance, making them feel at ease, definitely. And we've got a team ethos which shone through when I was having some chats with this team, and it could, sometimes I think we don't always realise how much we're collaborating together because of the small things that we take for granted, is what I gleaned from that conversation there. So it's acknowledging your individual strengths as well. Collaboration, we need some humour and we need some empathy. And being able to offer reasonable adjustments, which is really good for everyone, with the staff, the whole team and the patients as well. Keep options, questions open, not closed. Brilliant. Giving that choice through working together. And working together to show the needs of the patient, and working together again. Brilliant, lovely. Great, so well done, thank you. Oops. And then for empowerment, we've got generally making team feel better. Great. So empowerment by making the team feel better, acknowledging each other's skills again, encouraging each other and encouraging the patient as well. Give praise and acknowledgement. again, it's just recognising this, praise and acknowledgement for, but this is a really lovely one. Praise and acknowledgement for asking for help for both the patient, the colleague, the people that you work with. And praise good ideas. Praise all ideas, because they all start somewhere, definitely. Oh, and I love, be thankful. Be thankful for each and every day that you're working together, and for the people that come in and recognise their small things that they do and that you do for each other. And then it says, directing patients. Directing patients to the appropriate care. For example, A&E pharmacy 111. So that they're putting them back in control of the choices that they've got, so they know that they're helping themselves and taking responsibility. And then offering mental health support, IAPT, self-referral. Yeah, that's really good. That's a really good stepping stone to taking some positive moves forward. I think giving patients, missed one. Giving patients all the choices available and welcoming their opinions. Brilliant, yeah, because again, that's putting them back in control and giving back the power to the individual for what they're doing, which again raises that self-esteem and that confidence. So thank you, team. Thank you. And I'm going to pass you back to Dee.
Hello again. Some great answers there. Really, really thorough. Well done. So next we're actually going to have a look at when we're speaking to people and we're actually kind of showing our empathy and compassion. So to start off with, we're actually going to have a look at what not to do. So a lot of people may recognise things on this slide. I'll read them out in a minute. But they might have used them themselves, or they might have somebody use them on them. And actually, these things come from either being very busy and needing to move on, from protecting ourselves, or from trying to make people feel better. Because it's really difficult when we're dealing with people that are upset or they're in pain. And what we do as humans is we try and make them feel better. We try and say something that's going to make that better. But actually what happens is when we say something that we think is going to help that person, a lot of the time it doesn't. It actually pushes them away. So I'll give you some examples of this. So the first one, we've actually got the dodger, which you might find you doing if somebody's come in and they're in a really upset state, and you can feel yourself being pulled into it. So that could be, yeah, that really sucks. I hate to do this, but I have to run. I'll check back with you later. So it could be that you are really overworked, or maybe that you're at the end of your emotional tether yourself, and you just don't feel capable to do that. So we've also got the silver liner, which I'm sure we all recognise this one, and we've all either used it or had it used on us. So the silver liner is somebody saying, at least you don't have. So people do this because they care. You know, they want to make people feel better, but actually that can be really upsetting. So we've got the minimiser. It's not that bad. You know, when someone's in a bad place, or I'm sure you've had it yourself, I've had it numerous times when I've said something, said that I've had a really bad day, and somebody's like, yeah, that's not that bad. But actually, it does the opposite for what that person intended it to do. So the advisor. So when you've got someone on the phone and you know what they need, you want to tell them what they need to do, and you want to give them that advice. So, you know, they've rung up with an issue and you're like, oh, I can fix this. I'll give them the advice. It can actually work the other way. They may not want that advice. I'm not saying that giving advice is not a good thing, but unless it's specifically asked for, it can push people away. So then we've got things like the storyteller, where you may know someone that had exactly the same problem, you know, and this is exactly what they did. And you might want to tell them because, you know, that person ended up okay. But actually, in reality, they may not want to hear that story. And you've got the one-upper. You lost a parent. Yeah, I don't have either of mine. So again, it can be done from a good place, but it actually can sound not great to the person that's calling up with the issue or is talking about it.
It's dismissive.
It is dismissive, and I think that's the point of these, is that they can be very dismissive. Or we've got the drama, you know, oh my God, you poor thing, how awful is that? You know, that over responding to people telling you something. Or you've got the chin upper, you know, I'll keep your chin up. Do you know, I had an argument with a group once about chin upper because I was told by the group that no one used it anymore. And I was adamant they did. And then my friend rang me up that evening and she told me to keep my chin up. And I was like, that's where I've got it from. But you know, the kind of thing, you know, you'll be all right, just keep going, that kind of approach. And actually what these can do is they can really push people away. So I'm just going to give you a couple of minutes again. So if we have 5 minutes just to chat with each other and just talk about anything that you recognise on that list, or if you've used it, or if you've had it used on you and how it actually made you feel. So, go on. I can hear a lot of laughter, I'm sure, you two discussing what's been said to you in the past. But yeah, these things that we do, these are all really, really common responses to people, and really, really common when we see people in distress. Because we want them to feel better, we want them, and we think with being empathetic, but actually what we can do is we can push people away with them. And another thing that's used quite a lot is toxic positivity. So actually saying things to people that are in distress about how it will make them better in the future. Or, you know, there's a lot of different sort of comments around this, isn't it? And I'm sure we've all heard it, you know, all the bad things that happened to me made me the person I am. And, you know, you'll really appreciate this when you'll feel so much better when this is over. And there's the positivity. It's trying to put a positive spin on something. And actually, in reality, when someone is actually in a lot of pain, trying to put a positive spin on it is not helpful for them. It can make them feel worse. And actually, it's accepting that sometimes things aren't positive. And I think it's quite difficult nowadays because we kind of live in a toxic positivity world. I think you go on Facebook and you go on, you know, you go on Instagram and you follow these people that spin everything in a really positive way. And actually, it can be really harmful to deny the feelings, really, because some things in life are profoundly tragic, and it's the understanding of that. So how can we actually show people that we understand, show people that we're empathetic and we care? So it's really simple. So we can listen to them. So we can listen to understand them, and we can listen to understand their perspective and not put our own perspective on that. We can acknowledge. So we can acknowledge the feelings that people are having. And we can validate. And it's really important when we validate people's feelings that we accept that they're the feelings that they're having and we don't try and change it. Because that's when we fall into toxic positivity and we fall into those, you know, those quick fixes that we talked about. And actually sometimes things can't be fixed. And people will feel more heard if you just do these three things. Just listen to what the person's saying. Listen to understand them. Acknowledge the feelings that they're having. And really validate and accept their experience. And don't make it about us, because sometimes we can do that. And when I was doing some research for this, I looked on the NHS trauma-informed practice page. I've actually put the link in the end. And this came up, and I thought this was a really wonderful way of describing people. So it's a person with problems and not a problem, a patient with problems and not a problem patient. So it's really a good way to think about the people that come in and interact. That even if they come across in a way that you don't find, you know, that you find difficult, it doesn't make them a difficult person. It just means that they're having difficulties at the moment. And it's about really accepting that.